everyone. Today marks our return to a special type of episode known as our expert interview series. We had to pause it for a little while there, but we're back, and this episode is a good one. Today's episode is with Dr. Giselle Petzinger, a board-certified neurologist at the Keck School of Medicine at the University of Southern California, specializing in the care of patients with Parkinson's disease. One of the big take-homes from this episode is that a diagnosis with Parkinson's disease, devastating though it may be, is not the end of the story. This episode explores in exhaustive detail the power of exercise and deliberate, effortful practice of the neurocognitive skills that grant us humans our complex ability to achieve movement through space. Tango, boxing, tai chi, yoga, golf. These are all just a handful of examples that may help because they exploit frontal striatal neuroplasticity to restore some of the automaticity of movement that is lost to Parkinson's patients. These effects may even be somewhat separate from the neurotrophic factors released with high-intensity aerobic exercise, which has been shown to have a profound impact on Parkinson's disease as well. For example, some of the work coming out of Dr. Petzinger's lab showed that 8 weeks of intensive treadmill training 3 times per week can increase the expression of dopamine receptors in the basal ganglia by 80 to 90% in Parkinson's disease patients. Another 6-month-long study showed patients performing high-intensity exercise showed no disease progression, while non-exercisers experienced a 15% worsening of their motor symptoms. This is huge because no medications used to treat Parkinson's disease have been shown to actually slow disease progression. Exercise alone is still not a cure for Parkinson's disease. Dr. Petzinger is quick to point out that there may be cases when avoiding medication is counterproductive. While today's interview is primarily focused on the effects of exercise in Parkinson's disease, we cover a lot of ground, ranging from a discussion on the environmental causes and genetic origins of the disease, to dietary management of its symptoms with a special focus on DHA, a type of omega-3 fatty acid that may be beneficial not only in the prevention of the loss of dopamine-producing neurons, but also in the prevention of dyskinesias associated with levodopa, the dopamine replacement drug. One final note before we jump into the interview. If you or a loved one has Parkinson's disease, this episode is not intended as medical advice, and it is not a substitute for professional medical treatment or care. If you need medical advice, seek it out. Please enjoy this great conversation with the brilliant Dr. Giselle Petzinger, and watch out for more interview episodes like this one coming soon. Hello everyone, I'm sitting here with Dr. Giselle Petzinger, who is a clinical neurologist who specializes in Parkinson's disease. She is at the University of Southern California, where she splits her time between clinical care and research. One of the reasons I reached out to Giselle is because I'm particularly interested in some of her research on the role of exercise in Parkinson's disease.
Excellent.
So, can you talk a little bit about what Parkinson's disease is, maybe just from a basic standpoint?
Absolutely. So Parkinson's disease is a progressive neurodegenerative disorder. It's a disorder that affects individuals that are over the age of 50, generally speaking. So we consider it a disorder of aging. And generally speaking, we think of Parkinson's disease as a problem with mobility. In fact, clinically, that's how we tend to recognize it. And most people, when they're trying to, or feeling that something's changed, it's often because of mobility problems. And what I mean by that is slowness. People will describe feeling slow or dragging a leg, and or stiffness. So it has a kind of, as I said, kind of a motor movement, big, strong movement component. And then, of course, there's tremor. I think one thing, though, that people in general don't realize is tremor isn't necessary. So tremor definitely brings people in to see neurologists, and certainly it can be Parkinson's disease, but tremor can have other causes besides Parkinson's. So generally speaking, it's really more, I would say, about the slowness and the stiffness. And it can affect any part of the body, meaning it can affect the legs and therefore cause slow walking, as an example. But it can also affect the hands and arms, where people can actually feel that they can't use the arm as well. They feel that things are taking longer to do. And sometimes that might even be associated with some pain, element of pain. So as I mentioned, Parkinson's is sort of recognized as a motor problem. What we're recognizing more over time is that there's what we call a non-motor issue, many non-motor related phenomena that occur. And some of these non-motor phenomena can occur even before the motor, and people don't connect it necessarily with the Parkinson's. Examples of that may be loss of smell. Now, again, some of these other features are not specific. So none of these are specific. We're kind of evaluating everything together. But the non-motor features, as I said, could be the smell, changes in smell. Other non-motor, so that means things that aren't affecting mobility, could be mood, for example. So anxiety, depression. In fact, we're now realizing or recognizing, these are a number of papers that have come out now years ago, that anxiety, depression may even predate motor symptoms by 2 years. And that anxiety, depression may manifest in functional things like not being able to drive in a car, on the highway, feeling really anxious about that. And even family members may comment that the person just seems a little bit more depressed. So those things are now really well appreciated and recognized. Other things that are non-motor that again may precede the motor features are even what we call the autonomic nervous system. So the autonomic nervous system is part of the nervous system that involves or innervates smooth muscle. So this is things like your gut, your heart, your sweat glands, and those smooth muscles are part of your, as I said, your gut and your blood vessels. When they're not acting normally or behaving normally, it can cause disruption in your gut, like constipation. So constipation, again, in retrospect, we find people may have problems with constipation even before they describe and note problems with movement. Blood pressure, changes in blood pressure, maybe dropping in blood pressure or heart rate abnormalities because of changes in the innervation to the heart. These are all kind of examples of non-motor that aren't necessarily specific to Parkinson's disease, but kind of come together. Once we see the motor features, we can say, oh yeah, before that there were these other sorts of non-motor features that were already predating it. So the point is that Parkinson's is certainly more than that, and we're appreciating that more. And then finally, I would say now really coming out in the forefront, again, even more, is a cognitive issue of Parkinson's. And I think what we're recognizing is, again, cognitive issues are pretty predominant in Parkinson's. The literature is sort of all over the place, but essentially they're reporting about 40%, even upon diagnosis, may already have some cognitive issues. Now, that's not the same thing as dementia. So this is called mild cognitive impairment. And mild cognitive impairment is defined by the idea that a person may be noticing some memory-related issue, or their family members noting that, but they're not functionally impaired, meaning they can do all their ADLs, but they themselves are noting this. And we can actually pick that up on some diagnostic testing as well. So these things, again, happen quite early. There's some understanding of why this may be happening, but they're certainly part of Parkinson's disease. And also the idea that they are very much interrelated. So motor and cognition probably have some relationship too, in terms of the idea that cognitive issues can sometimes contribute to more motor problems, or cognitive issues can contribute to more mood-related issues. So they're not really separated, they're very much interrelated, and we're beginning to understand how and why that may be happening, either from a neurochemical point of view or from a circuit point of view. Yeah.
So thinking about what's actually, causing Parkinson's disease, you're talking about this overlap between the cognitive issues and the motor dysfunction, and there may be a big connection there. From what I read is that Parkinson's disease is associated with a loss in the dopamine producing neurons in the substantia nigra.
Right. Mm-hmm.
And I had read somewhere that you lose anywhere between 50 to 80% of them before you actually have a clinical manifestation. Right. Is that
right? So you're right. I mean, so the idea is that there is this threshold phenomenon with Parkinson's, and essentially, it is dopamine loss is a big component of what the manifestations of Parkinson's disease. We think about it as actually about 40%. 40, let's say, to 50% cell loss.
That's a lot.
And 60 to 80% dopamine loss. So there's a bit of a disconnect between the amount of cell loss and dopamine depletion. And the reason that's important to say it that way is because the idea that Parkinson's is cell loss for sure, but it's also cell dysfunction. So remaining cells that are still there are also having some problems as well. And that's important because it may play out in terms of some issues that happen over time with how those remaining cells handle dopamine. Things like wearing off and dyskinesia and these sorts of things that manifest later on may have some role to do with cell dysfunction as well. I think the other point to bring out is, we tend to think of the behavioral features of Parkinson's disease as sort of being this one-to-one with dopamine cell loss, the idea being like, I've lost another cell, now I have tremor, But the reason, so I want to clarify a couple points. So dopamine loss is clearly important, but what we're recognizing more and more is that behavior at the end of the day is circuit, right? So the idea is that dopamine is actually impacting circuitry. So when dopamine loss occurs, one of the fundamental things it does is disrupt circuitry, and it's that disruption of circuitry that causes behavioral problems. So where is the circuit problems that are underlying these behavioral issues? Well, we can take the motor circuit as an example. And in the motor circuitry, we know that there's a couple big areas of circuits that are involved in motor control. The biggest one we talk about is that of the basal ganglia, right? So the basal ganglia to the cortex, cortical striatal. And that's essentially responsible for what we call automaticity, automatic movements. So this is movements that have been learned, practiced over time. I mean, so you don't come out of mom's womb like walking around and dancing, right? So you have to practice this over time, and so there's this element of practice, multiple practices that get you good. Dopamine is actually important for facilitating synaptic plasticity there, and there's a couple forms that are developing in that stratum. LTD is the predominant form that's thought to be occurring there in the stratum, particularly with motor control. The issue, though, is that fundamentally it's practice. So it's practice with dopamine as an enabler. So when dopamine levels are dropping, you're losing functional and physical connections, and we see that. We know that that's happening. So the behavioral issue is probably the circuit itself. Now, the reason we care is because there are other circuits involved in motor movement through space. And one of those things is the frontal striatal circuit, as an example. And I'm going to kind of keep that simple because there's other circuits interacting with the prefrontal or frontal system. But the idea behind the frontal striatal is sort of volitional movement. So my ability to kind of update movements, my ability to move into new spaces, and actually my ability to learn new movements. So that's sort of what we call a volitional aspect of movement. So you have the automatic movement, you have the volitional acts of movement, and they're happening together all the time, right? And so if I'm losing my automaticity, if I'm losing that circuit hard because of dopamine depletion, I can compensate. I can absolutely compensate by kind of adapting towards a more volitional type of movement. And if you ask patients with Parkinson's, they all do that. They'll tell you, I have to think more about movement. And so the reason that's also interesting is because that same circuit, many of those same circuits have sort of dual behavior. I mean, it has a cognitive behavioral aspect of it, of what we call the executive function, which is planning, processing, all those sorts of things that you're also kind of doing day to day. So there's sort of a saturation effect happening here. I'm now dependent on it more, and I'm also using it to plan my day. So is that sort of the tipping point right there? I've saturated, and now that I can't do it anymore, now that I can, it doesn't take much for me to fall because now I'm using it already, all cylinders are firing, and now I have, now I have to hold plates and walk to the kitchen or something like that. I'm kind of super saturated that frontal system, and now I'm falling, right? So that's why this whole idea of compensation and threshold, if we bring it up to the circuit level, that may also begin to explain this, if that makes sense. And finally, on the back end, the idea of the role of cerebellum. So the cerebellum also plays a pretty important role for motor control, for motor planning, has a cognitive aspect to it as well. And the idea here is there's a lot of good data that shows, for example, in Parkinson's models, that when we have an animal, just in the beginning aspects of learning exercise, that cerebellum is on fire. It's lit up like a light bulb. So we have two other circuits that are trying to adapt. And so these are kind of principles of what we're going to talk about in just a bit, but the whole idea of what neuroplasticity is and the fundamental aspects of brain change and homeostasis, which is reaching a new level of balance or homeostasis so that the brain can function, if you will. And what's interesting about that is that you begin to see those are all sort of contributing to the Parkinsonian features, right? So the dopamine depletion with the loss of automaticity, and then these other compensatory circuits. Is that good or not good? Is that contributing to some of the symptoms or not contributing to some of the symptoms? So brain changes that happen in the brain because of injury, or in this case, dopamine depletion, leads to a lot of adaptation, some of which is good in terms of behavior, and some of it may not be desirable. So it has a kind of an interesting concept from the point of view that it may be accounting for some of these compensatory strategies, it may be allowing for some threshold. At the same time, it may be causing some problems down the road.
Right. Yeah, definitely. You're kind of touching on things that seem to be important with exercise and practicing certain types of goal-based sort of exercises. But I kind of wanted to ask you a little bit about, before we get into that, just, how many people, I don't know, worldwide in the U.S. have Parkinson's disease, and maybe some of the environmental versus genetic causes of Parkinson's disease, or what we know, what the field knows about that?
Right. So, I think in general, so the idea is that 1 in 100 over the age of 50 have Parkinson's disease. And don't know the exact
number. So it's what, the second leading neurodegenerative disease?
Yeah, definitely the second
behind
leading,
Alzheimer's,
behind Alzheimer's. And I think in terms of genetics, so in general we think that genetics play, and certainly there are genetic risk factors, but in terms of strong genetic contributions, most of that data seems to be in young onset. By young onset, I mean younger than 35, for example. Not as common over the age of 35, although now certainly we're recognizing that there are these risk factors like LRRK2, for example, where they may be running in certain ethnic groups where there may be some higher predisposition.
LRRK2 is a gene.
Right, LRRK2 is a genetic mutation. But still in general, I think the idea is that most of these genetic predispositions are happening in younger onset people, and that in the older, and again, older being anybody over the age of 35 as an example, or over the age of 40 at least, that there's probably a mix between environmental and genetic factors. And we've heard that, again, by some work by a number of very important investigators who've been able to show us, some of that epidemiological data, which is the idea that there's been some higher risk in rural settings than in urban settings, the idea that environment does seem to play a role. And so in general, we would say, still in Parkinson's disease, that it is sort of, there's a number of different risk factors. Some may be genetic. As we get older, those genetic influencers may have some specific role in certain populations in general, but that we would say that it's environmental risk factors, and maybe even things that play a role in genetics that are related to metabolism, how we metabolize, for example, if they're herbicides, right? And also the other genetic aspect of it is still questions related to plasticity itself. Repair mechanisms is another example. So you can see that it gets complex pretty fast in terms of what genetic risk factors may be and what environmental factors may be. And I guess the point is people are beginning to recognize that Parkinson's may be kind of a common final pathway of a number of different mechanisms, which kind of makes it challenging in a way, because trying to isolate every single one of those targets can be hard, because there may not be one single risk factor, for example.
Right, exactly, yeah. I was talking to you a bit before we started rolling that basically the field seemed to really advance back in the 1980s when this precursor to our neurotoxin, MPTP, was found to basically cause Parkinsonian symptoms in people, I guess chemists and stuff that were synthesizing it, or even I think IV drug users.
It was actually IV, IV drug users. The chemists seem to not get the problem, but the IV drug users, right? Exactly.
And the basically this this neurotoxin essentially inhibits mitochondrial function. It crosses the blood-brain barrier. It can affect all sorts of brain regions and dopamine neurons. But the thing that was very disturbing was the similarities between some of these insecticides and herbicides like rotenone and paraquat that essentially have the same mechanism of action, also can cross the blood-brain barrier.
Right, absolutely.
And are used as in animal models.
Exactly. They're very effective, aren't they? Yeah, I think the thing about it that obviously that the finding of the MPTP in the 1980s. So to clarify, essentially what happened was in the 1980s, there was a sort of an outbreak, if you will, of Parkinson's. And what was so unusual about it is that these particular individuals, and there are about 8 individuals, let's say, that presented around the Bay Area in various emergency rooms, had essentially developed Parkinsonian features overnight. And nothing like that had ever been seen. And there was sort of some really interesting investigative work that had been done to try to identify what was the commonality between all these individuals. And what they found right off the bat was they had been heroin users, and that they had gotten some access to some, synthesized heroin, essentially, that had been tainted with this protoxin, if you will. So MPTP is sort of a protoxin. It gets delivered to the brain, and there it gets converted to MPP+. But in essence, they were not aware, of course, that this was in kind of the heroin itself, and it had been synthesized inadvertently by these chemists because they had changed the protocol, if you will, in how they were synthesizing this compound by changing the temperature. Simply changing the temperature of the reaction had brought out this particular toxin. And when they injected it directly into their vein, they essentially blew out their nigra, so it killed dopamine cells. And we know that for a fact because for some of these individuals who passed on, the brains were looked at, and also they had gained access to some of the same material and used it in primates and were able to replicate Parkinson's, essentially be able to see that they had killed cells, that caused dopamine depletion, that it disturbed circuitry, and that it caused motor impairment like Parkinson's disease. So the difference was this was acute. Right, but I think what was so important about that was that it created a model that we could study. Two, it validated the whole idea that there are environmental products or environmental exposures of toxins that could absolutely contribute, right, to a neurodegenerative disorder, and so that it kind of reconfirmed this epidemiological data that rural aspects of where you live may influence, or contribute at least to this kind of disease of aging, maybe accelerating it, or certainly in this situation, bringing it out even faster. So, again, affecting how fast people may get it.
Right, and I think you mentioned earlier how there's probably a lot of combining factors, perhaps additive in some cases. So you may have higher exposure to some of these pesticides as maybe you're a farmer. In fact, farmers have been shown to have a higher incidence of Parkinson's disease if they're working with paraquat. So, in combination with other things, maybe being sedentary and having a lot of inflammation, and just like the perfect storm of environmental factors that can increase your risk. So
exactly, and I think that's the point. It's hard to necessarily always pick out one thing, and this what happened to that MP, obviously to this, what tragically happened to these individuals. Fortunately, we've never seen an outbreak like that since then. But it does sort of point out the idea that, that there may be a contribution of things either over time or a number of different risk factors that can certainly contribute to this. Right.
I think with those two in particular, rotenone is an insecticide and paraquat is herbicide. And I know that rotenone, I think, is really only used now in the U.S. to kill fish, like a piscicide or something it's called.
Right.
I don't know how much of it's in the water.
Right.
I mean, it's kind of like, all these things to think about, but paraquat I think is like pretty much phased out. You have to really have it's restricted use in the U.S., maybe in developing countries and stuff. But the question becomes: should I worry about if I have my produce is not organic, but I'm exercising and I'm avoiding refined sugar and I'm doing everything else. Maybe it's not such a big deal. I don't know. Maybe I have a genetic risk factor. Maybe I don't. There's a lot of things to consider. Maybe you don't want to have a complete fear. I've decided I'm eating organic just because I do eat a large quantity of them, and some, blending them in smoothies and stuff. But it is one thing to consider of many different, possible risk factors. So one of the probably most compelling lifestyle factors that, at least from my reading and certainly from research like yours, that seems to impact Parkinson's disease in a positive way, meaning decreased risk. And also seems to be associated with, modulating the severity of the disease is exercise. So there is literature that has linked a decreased risk of Parkinson's disease with people that are more physically active.
Right.
Am I correct?
That's correct.
Yeah.
Exactly.
And I mean, exercise is pretty much, it's like a panacea. I mean, you're talking about decreasing the risk of Alzheimer's disease and in fact, it's been shown to help, with recovering from traumatic brain injury. In a way, Parkinson's disease is kind of like a traumatic brain injury, like just extended out. Right?
Yeah. No, you're right.
Not something that just...
Yeah, and I think that's also why... So exercise, obviously there's a lot of interesting data, compelling data, certainly from an epidemiologic point of view, that it may lower risk for Parkinson's disease. I like to kind of think about exercise and lifestyle in general. Obviously, we're going to talk a little bit more specifically about exercise. It's sort of the counterweight to everything we talked about before. So the idea that, multiple things, genetic risk factors, environmental risk factors, and disuse, if you will, of lifestyle factors, kind of contribute to brain injury, brain changes over time. So sort of an insult, if you will, to the brain that bring out diseases. Parkinson's is an example of that. And it sort of plays out fundamentally at a circuit level, meaning behavior is what is underlying circuitry. So if we see behavioral issues, then whatever that damage is occurring is happening because of synaptic connection losses, either physical loss or functional loss of connections, right? So then you can think of lifestyle exercise as an example, as sort of being the counterbalance of that, where whatever those mechanisms are, which we can talk about in a little bit more detail, are promoting, right? Or promoting these sort of synaptic connections, maybe keeping them healthier, facilitating them, or maybe driving some of these compensatory circuits that allow me to function day to day. So I think the kind of cool thing about exercise is to think about it in the idea that it is a type of counterbalance, right? And so it may not be necessarily targeting every specific mechanism of every toxin or whatever those insults are. It provides a type of repair model that allows some type of resilience, so the idea of resilience. And I think that's important because it gets kind of to the idea of aging, if you will, and these insults, if you will, is sort of a part of life, kind of a spectrum of life that is ongoing, right? So the idea is that we don't live in bubbles. We're always going to have some type of exposure. So exercise and lifestyle sort of gives us this continual spectrum, if you will, of kind of a repair, ongoing repair, kind of the ongoing counterbalance that allows me to deal with this disorder better, so that the modification and or be sufficient enough for me to not even hit the threshold of the disorder, of the diagnosis. And what's interesting about that too is there's also a bit of a disconnect, if you will, between the pathology load and some of these circuits as well, circuit impairment, for example, or circuit repair. I give the example of Alzheimer's, right, and amyloid. It's an example where people have looked at, for example, the nun study, where nuns had basically been giving writing samples over time and showing, their level of education and cognitive capacity, if you will, and yet having a fairly significant amyloid load. So it just goes to, makes you think about how much of whatever these lifestyle factors are interact with some of these protein aggregates, Parkinson's being another one, either directly or indirectly. So, it may not all be about removing protein load, but it's still able to do something beyond that in terms of maintaining some type of synaptic integrity or function. And I think it also gets back to the idea that when we think about, kind of benefits of exercise, there still could be, even though I'm able to function better and stuff like that, it doesn't mean that my brain doesn't have some changes, So there could be still some evidence of injury. All I'm saying is that nothing's all perfectly lined up in terms of pathology, behavior, and circuitry. It's what we're trying to understand. And that's now, so in the context of exercise, the model that exercise offers is sort of the counterbalance to all the injury sides. So exercise offers us this model to understand all the reparative mechanisms, all the resilience mechanisms that we believe at the end of the day are playing out at a circuit level. Does that make sense?
Yes. So basically, what you're saying is that in a way, the exercise is activating all these resilient pathways. It's activating pathways that are involved in maintaining connections between neurons, making them stronger, in repairing damage, in just a variety of growth factors that are important for all these signaling and so because the exercise in a sense is a type of stress on the body. It's something that we actually evolved doing. Before we were in our industrialized society where we sit in our office in cubicles, we were out hunting, gathering, getting our food and moving a lot. Right, we were moving. We were meant to do that.
Right.
But it is a type of stress that activates all these resilient pathways, and so in the face of another type of stress, whether that's Parkinson's disease or Alzheimer's disease or just the stress of aging, you're going to be more resilient to that stress. Like you're going to deal with it better. You're going to have more of this brain-derived neurotrophic factor that helps repair damaged neurons than you would. So even though you're not going to take away that challenge, the challenge will be there. We're all aging.
Right.
You're just going to do it better because you have more of these, resilient pathways that are being activated.
Right, that's right. And so in a way, it's sort of a continuum then. So then you kind of don't think of it as before the disease, during the disease, or it's just always there. Right. And so you're kind of moving forward through an aging process with all these other risk factors happening that are causing without a doubt, some injury at some level. And so, I mean, the importance of us understanding exercise as a model of a mechanism, it's really trying to understand better what the brain is capable in terms of repair mechanisms. What are we really enabling there? What's the counterbalance to injury that we're able to tap into that allows us to compensate at a significant level? And again, Parkinson's disease, remember, I mean, think about that model itself. There's a threshold there. I mean, I've lost, 40% of cells before I'm showing functional impairment, right? So that's important because it gives us an idea that the brain may be able to tolerate some level of injury, if you will, and through optimization, which we still believe has to happen at a synaptic level because behavior is synaptic. So to get functional improvement, behavior, you need something at a circuit level, right? So it's more than just cells. That's the other important thing here. That's huge, understanding those reparative mechanisms. And so I think for people in the exercise field, obviously we're thrilled that we can, be able to understand this better, to enable people to do more things and to be more involved in their own care and these sorts of things. I think the other bigger issues are kind of the field of reparative mechanisms itself. It's sort of like, we think about space as a final frontier, but there's so much we don't understand about how the brain is able to drive repair mechanisms. What's the limit of that, which is very interesting.
Yeah, absolutely. I think that, and not only just, we're talking about exercise in a general term, but like the specific types of exercise, right? And how they're, maybe, differentially improving, there's different repair mechanisms happening when you're doing a high intensity interval sprint versus resistance training at 60 or 70% your max heart rate, or treadmill walking and coordination, and so there's all different types of exercise.
Absolutely. And I think so there's the issue of the different types of exercise, and also kind of getting into that discussion. Sort of underlying that is obviously the mechanism question, right? So are they doing something differential, right? And I think the reason we care about things like that is because I think one of the general early concepts of exercise in general has been really more about body's effect on the brain, as though the brain is a passive recipient of all these sorts of benefits somehow, right? I think when we're teasing apart these different types of exercise, I think one of the questions that come up is, we care about these different types of exercise because we do believe that there are certain circumstances where the brain may play a more active role, meaning it's driving some circuit-specific effect. And what I mean by that is this whole idea, for example, if I'm more engaged in what I'm doing, if I'm more top-down, cognitively involved in my process of movement through space and learning something, that I may be activating certain circuits, right? And that activation of circuitry, by virtue of using it harder, may itself drive some of these benefits,
Can you give an example of that type of physical activity?
Right. So, for example, let's say something that would be more skillful, right? So where I'm actually having to get better at it, it's actually quite challenging. For example, we're in Southern California, so surfing as an example, where I'm not only considering, obviously, how I'm balancing on the board, but I'm watching the waves. I'm thinking about my speed getting up on the board, my weight distribution. So there's a lot of different things I'm thinking about as I'm trying to get better on that. I fall off and I do it again, and getting through a lot of different practices. So it's a lot of practice, repetition, learning, feedback, where I'm really thinking hard about what I'm doing. So that as a skill versus, for example, a stationary bike, right? Where I'm just moving, just moving my legs, trying to get up to a certain speed, but maybe not having to think about balance as much, these sorts of things.
What would be an example for someone, for example, that has Parkinson's disease? They probably aren't going to be out surfing.
So an example, so Tai Chi or yoga as an example, right? Yoga. And boxing as an example.
So non-contact
right.
boxing.
So, but also even in physical, many of the physical therapists, what they'll do as an example is just even gait and balance practice, making it harder. Anytime you're making something harder, more challenging, whether it's through balance, whether it's through weight change, through dynamic balance, working harder with dynamic balance, speed. You get the speed up, you have to make it more accurate. All those sorts of things is going to make it harder for you. So the idea would be getting out of your comfort zone, problem solving, how to get more accurate, how to get that speed up, how to become more dynamic on that task. And as I said, that can be done even with a physical therapist working on gait and balance, right? that itself is going to be more skillful over time.
So the skillful exercise that you're describing seems really independent of talking about something else, which would be the intensity of your exercise, the vigorousness, like that's another aspect. What you're talking about specifically has to do, I mean, you're obviously getting physical, you're getting some physical activity, but it's a very specific type of activity where you're focusing on something, you're getting that feedback of learning, and you're basically engaging your brain a lot more than just like
and I think fundamentally you're sort of getting at the two kind of discussions that are going on with exercise. Actually, there's other discussions with muscle resistance and those sorts of things. But I think fundamentally some of the questions that are coming up are intensity in the context of learning. So one is learning, more about motor learning, right? Which is definitely requires lots of practice and challenge and to get good, right? Like tennis as an example, right? And the other type of intensity was the heart rate, getting your heart rate up, feeling your heart pounding in your chest and sweating. That's also intense. So they can both be very intense, but for different reasons, right? So one more from the aspect of learning and practice and problem solving to get better at something from a physical point of view. So things can be very physically challenging to learn, like skateboarding or Tai Chi or yoga. And Parkinson's disease, the bottom line is their gait isn't normal. The balance is not normal. We're starting all over again. So this is not normal walking, right? And this is not normal dynamic balance. They have impairments in that. So we can start at that level. We're concentrating on getting their balance better, the walking stride better, the posture better. All those things are what we call more normal automatic gait. That's practice to them to get it good and to make it harder.
And now is that as the disease progresses, those things are dysfunctional? Or you're saying like from
the beginning right. We're already working on it and making it harder. We can make it harder yet. I mean, we can make it, have you be more accurate with it, make you go through an obstacle course. So we can make it harder yet to get you even better for balance, as an example.
No, what I was saying is when someone's diagnosed, like does their balance, like for example, if they were just diagnosed, are they going to be having problems with their balance, or is that as the disease progresses? Is it variable?
No, it is as the disease progresses in general, but gait is very common. I mean, not normal gait, so they'll have a slowness in the gait, for example.
And by gait, you mean like how they're walking.
Exactly.
Like just
yeah, so I mean, we tend to target, and that's why you see many of the exercise programs really target gait and balance. Because many times, so people definitely can have slowness in their hand and stiffness in their trunk. But targeting gait and balance is huge, because that's really ultimately probably where the biggest deficits are. And many times in targeting gait and balance, you're really engaging different parts of the body as well, arm swing, posture, and these sorts of things. So it's a good place to start, if you will. Now, obviously, you can add more with things in your arms, boxing example, that way you can add more and make it more complicated tasks.
And these people that are doing this rock steady boxing, as it's called, the non-contact, are they just like doing like a bag, or is that?
Yeah, so I have to tell you, I've never gone to a rock steady boxing class, but the idea would be that, they're learning different types of patterns of movements, for example. So it may not just be pure moving of the arm, but it may be a pattern that they have to replicate, for example. So that would make it more skillful.
Skill that you were talking about.
Exactly, right. And I don't think anybody thinks that one type of exercise necessarily negates the other. There's no... no one thinks that one is necessarily better. They're just different.
Yeah.
You know what I'm saying? And I think fundamentally the reason we care is we think that the mechanisms which underlie them may be different.
Right.
And that's why I think in terms of some of the work we're doing, we're very interested in that idea. And some of the work that a colleague, Dr. Holschneider here at USC has shown is certainly in the animal models that we've been doing, looking or trying to separate out or tease apart these different mechanisms, where one group of rodents with Parkinson's have gone through a type of exercise practice more skillful, meaning they're on a motorized wheel with spokes removed. Animals definitely need to pay more attention, versus a group of animals, Parkinsonian, where there aren't spokes removed, so it's nice and smooth. They don't have to think as much about what they're doing. Same match for speed. The animals that have the spokes removed have blood flow in top-down circuit cognitive domains much more so than animals that don't. So kind of the proof of concept that, okay, if exercise is just exercise, we shouldn't be seeing differences in blood flow to different circuits.
Wow.
Right?
Yeah.
Right.
So they were doing the same intensity.
Yeah.
Wow.
Right. And so, again, why do we care? I think the biggest thing, honestly, is that it's just beginning to say, hey, guess what? The brain is not passive. This is not a passive effective exercise. The brain is engaged very much in this reparative mechanism and is driving this effect. So it's not just take blood and dump it onto the brain. It's like, no, the brain is an important signal of this effect. And that's huge to think about.
I also think to some degree, maybe this is like with the animals, like there wasn't like a dose that you haven't, maybe a dose response would be an interesting thing to do as well in terms of intensity, because I know from experience when I go really hard, when I'm pushing my intensity to something like 80 to 85% of my maximum heart rate. And by the way, people usually aren't measuring their heart rate. Like, I have like my watch and stuff and all that. But for people that aren't measuring the heart rate, would you say a good gauge is sweat, getting flushed in the face? I mean, this isn't like walking your dog exercise.
That's right. Yes, that's right.
You've got to like push
out of
it.
your comfort zone.
Yeah,
right.
Push it past.
Yes.
I have to think about what I'm doing a lot more.
Right.
Like even though, let's say I'm at a spin class. Okay?
Right.
And it's like if I am pushing it to my like 80% max zone, I am more cognitively engaged.
Yes.
Absolutely, for sure.
Yes, right.
Than when I am doing like 50%.
Right. Yeah, no, you're right. And I think speed, I mean, that's true. So there's a speed component, right? Where so as you get faster, you are thinking about accuracy a lot more, and you are starting to. You're right, absolutely.
Kind of more confident.
And I think the point that you're bringing up, which I think is so important, is it's a spectrum, isn't it? So it's not really often just one or the other, right? There's some that have certain types of activities that are going to have higher aerobic content maybe than skill. But as I've often been reminded by many of my physical therapist colleagues, it's like it's actually also kind of impossible not to have some level of skill in anything you do. I mean, it's hard to be completely mindless on whatever you're doing. Obviously with weightlifting, even the weightlifting is requiring some cognitive loading.
You don't want to get hurt.
Right, exactly. I'm not just like throwing weights around. So the idea is that there's always some element of skill, even in biking, even in a stationary bike, because you're thinking about your speed. It's kind of the issue of degree and also, again, the issue of intensity. Right. And that the two are probably, obviously have different types of mechanisms that may be contributing to repair, but the idea is they may be different. And particularly when we're thinking about cognitive circuitry, as an example, we may want to be thinking about how we could add more cognitive loading, right? And what's curious about this sort of idea of cognitive loading, many times when I talk to people about cognitive loading, the first thing they want to do is tell me about a crossword puzzle they've done, and I'm going, well wait a minute. Now, our brain has evolved to be pretty effective in movement through space. I mean, it's pretty, pretty on board when it tries to figure out how to get from point A to point B. I mean, it's been important in our evolution. It's probably why we're still living today, because we've been able to avoid animals that harm us. We've been able to be successfully going for meals. I mean, the idea of movement in space is huge for us. And the point there is that that's cognitive loading. Myself, of just problem-solving movement through space, whether that be because of the skill that I'm engaging or even through a different environment, right? So the idea of mixing that up, changing the environment, is going to be another type of cognitive load.
There's been animal studies that have shown that doing that exact thing, like changing the environment and particularly putting an animal in a more enriched environment, it increases synaptic connection, long-term potentiation,
right, absolutely. And what's interesting about that field, though, is even in the context of environmental enrichment, many times it's also what else is in there, like the wheel, there's always a physical component that they find is also important. So I think it kind of just, as I said, kind of goes back to the idea that movement through space is a big deal for our brain. It itself is a cognitive load. We can definitely ramp that up in a lot of different ways. Certainly, from a skill point of view, we can. From an environmental enrichment, making it a novel environment for us, moving effectively through space is also, in a new space, in a novel environment, is also pretty big. I know there's a lot of interest now looking at natural spaces and what that does for cognition as well. And there's some really interesting things coming out of that. Again, kind of tying it back into movement, though, is really where it gets really interesting. Yeah.
Right. I mean, certainly, so in addition to, all the benefits that exercise, there's been studies showing that, in even Parkinson's disease patients that do, a certain amount of, 30 minutes of exercise, moderate to high intensity increase BDNF in their plasma, and BDNF crosses the blood-brain barrier. It's a growth factor. It's important for maintaining synaptic connections. It's important for growing new neurons, and certainly important for repair of damaged brains.
Right,
so
absolutely.
There's definitely lots of factors that probably, as you were mentioning, there's the the combination of these things. That exercise is anti-inflammatory. You're making anti-inflammatory cytokines,
Right.
and those things also are doing stuff in the brain.
Absolutely.
As you mentioned, the brain and body are very connected. They're not disconnected like we thought. In fact, the immune system, these immune factors are getting into the brain. Our lymphatic system is connected.
Absolutely.
So there's definitely a connection.
Absolutely.
There.
I think the one thing in tying back, kind of what you were saying, so this whole idea of how connected, obviously, as you said, we're learning a lot about that. But also, again, the idea that, which I always like to emphasize, that the brain is not a passive recipient of this, meaning there's a lot of signaling we're probably just beginning to understand in terms of what the brain needs. And the idea that as you kind of create these sort of metabolic demands on these circuits by virtue of how you're using your brain, right? By virtue of the taxing nature of skill and the taxing nature of a cognitive load in the context of movement, that those neurons and those synaptic activity and that high metabolic demand is signaling the need for more fuel, and so the idea there is all those sort of pathways that are, metabolic in nature, that and driving changes in blood flow, that are also kind of interesting because, like I said, I many times we do tend to think about these sort of lifestyle effects as sort of being this sort of global kind of glow, your body glow. It's sort of like it's this sort of wave of your whole body that suddenly gets better. It's like, well, no. It's very active, and it may be even more specific than we think. And I think, as I said, the brain is a great model to begin to understand that because it has some kind of cool repair mechanisms. The question is, how does that signaling start? How much of that is brain driven, right? And top down. So we're not even talking, from the periphery in. I'm talking from the brain out. Brain is signaling to the periphery, what do I need now to be able to accomplish what I need to accomplish, reaching my new level of homeostasis. I am asking for a new level of a type of connection that I now need. I'm going to signal for the type of whatever support I need to make that happen, right?
Do you think there's I was talking with your colleague who happens to be your husband earlier about we were talking about the exercise and the lactate that's induced from exercise. Now this isn't I'm not sure if there's a signal, basically lactate's being generated and it's crossing the blood-brain barrier and getting to the brain. I don't know if there's a reason for that. I mean, your astrocytes make lactate.
Right.
They're highly glycolytic. In fact, mostly I think they're using glucose to make lactate.
Right.
That's shuttled into neurons and used as a very easily used oxidizable source of energy, but also it acts as a signaling molecule and it's affecting BDNF and other things. And so I just thought that was very interesting that there's another possible mechanism that exercise is like you've got this lactate that's being generated and the brain wants it. And I don't know if it's like there's it goes to other tissues as well. I don't know if it's how much goes in the brain. I mean, he was saying quite a bit.
Right, quite a bit. And I think the other thing, so it is one of the interests of the lab in general, which is understanding how does lactate, how can we signal the need for lactate in the brain, or how is the brain using lactate in the context of exercise, and what is the upstream mechanisms for driving the signal. There are a number of different pathways that people are looking at, but one of them are transcription factors, and hypoxia-inducible factor, HIF alpha, is one example of a transcription factor that is known to be upregulated in the context of hypoxia. And now ourselves and other groups have reported some upregulation of this in the context of exercise. So the idea of a stressor, right? So the idea of this sort of disconnect between what the neuron is doing in terms of activity and the metabolic demand. It itself may be driving transcription factor changes that then may upregulate metabolism or alterations in lactate transport, as an example. Right. And that's some of the interests that we have right now, which may be metabolically driven. So the idea is that neurons, through activity, are, as I said, upregulating transcripts that are detecting this mismatch, if you will, that may change metabolism, right? And then allowing for better use of glucose or even use of peripheral lactate through changes in transport and blood flow. So that's kind of cool, right? So now you're kind of thinking about peripheral effects, whether that's immune atrophic factors on one hand, and then you're thinking about signaling that is centrally driven by stressors, We certainly know cancer can do that. As an example, it's kind of ironically a kind of an interesting model for us because it kind of does the same thing, and it changes the demand on the brain. It's changing the metabolic demand that it needs, and it's changing blood flow to the tumor itself. And we're sort of seeing those sorts of things with exercise based on how we're using circuitry. Which is interesting, right? And I think it kind of all goes back to the idea of what homeostasis is, right? So the idea that homeostasis is sort of trying to reach this new type of balance, this new type of so brain change that's responding to injury, that's responding to a new demand on the brain, right? That it recognizes where it's beginning to need more fuel, better blood flow, more support, and that we can influence this to some degree based on what we do, right? Which is crazy, right?
But didn't you also publish a few years ago, you had a very small pilot trial where you showed patients with Parkinson's disease early diagnosed, I think they were medication-free even, and you had them doing this sort of moderate to high-intensity treadmill exercise, and it seemed to change the sensitivity of their brain to dopamine, or to the receptors, dopamine receptors.
Exactly, yes.
So like they're basically using it better,
right?
Like, the little they have, it's better at it,
Right, more efficient, yeah. So that was another thing that we had seen, which is actually changes in dopamine receptors, right? So the idea was that we had taken patients who had not been on anything and essentially, no meds anyway, and were really recently diagnosed and then putting them on a treadmill. And I would argue that although the treadmill, again, so intensity in two ways. One, obviously getting their heart rate up, but they were actually also getting a lot of feedback on gait and balance. Again, constantly correcting, going up on speed. So they had to become more accurate.
So having like a personal trainer seems to kind of be very important.
Yeah, they were getting tons of feedback. And by going up on speeds, now you're having to work harder to make sure you're accurate. So again, you're in the zone, if you will. But in any event, yeah, so we were able to show that we saw changes in dopamine receptor levels, with the idea being that the amount of dopamine you have with a better receptor expression, you're becoming more efficient. And that was duplicating what we saw in the animal model. Right. So this was kind of nice to be able to show it in both a rodent model and translate it to humans.
It goes along with the adaptations you were just talking about as well. And
Absolutely.
I would ask though, for someone that does have Parkinson's disease, it sounds like having a personal trainer may be a good idea because you're getting all of these things that you're mentioning. You're getting that feedback. You're getting someone to help challenge you more. It's that challenge. You don't want to just be in your comfort zone like you would if you were walking your dog.
Right.
You want to push yourself more. Right. And so it helps to have someone.
It does.
Or a group class.
It does.
With feedback and.
Right.
It's.
Yeah, I think it's great. You've touched on a number of different things. I think first of all, number one, I think. In general, we like having patients with Parkinson's have exposure to physical therapy one-on-one periodically. And I think the idea there is what you've said for a couple reasons. Obviously, one, you want to make sure you're challenging yourself. You want to make sure you're not hurting yourself. But also, you really are gaining kind of a tool set and feedback on what you need to be working on. And it is, as I said, getting the feedback to be accurate and problem solve to do it again better, right? And so, you definitely want to progress and get better, number one. And two, you can kind of use those tool sets to, apply now to a class, which is, so you're doing, what your class, but you kind of know what you need to be working on. So I kind of like that combination. I think the other thing, so getting that one-on-one, I think is always great. And I think for Parkinson's, that's particularly true because they have some deficits that they really should be working on and focusing on. Getting that feedback is important. They may not recognize it, so that feedback is important. The other thing I was going to say is, I like people also to kind of mix things up a little bit, do a lot of different things. So, once you try one thing, maybe mix it up and do something a little different. I think that's also important. Doing something you love, the whole idea of self-belief, is self-efficacy, self-belief, the idea that you're going to do better if you believe you can gain benefits from it and if you enjoy what you're doing are really key. And so I think that's also why the idea of obviously getting some feedback from physical therapy, but then doing something you love, you enjoy, you want to learn is good. Mixing it up both from the skill set, your different things, and mixing it up from the different environments. I always say, look, we live in Southern California. We've got, I don't know how many different types of terrains here. It's not that hard to mix this up. So it's really going back to the idea of mental flexibility, exploration, and fundamentally play. Yeah. It's play. which is all those things. Really.
Definitely increases compliance that you'll keep doing it if it's something you enjoy doing and like
play,
doing.
right?
But to a certain extent, you also want to make sure it's not. I mean, it's play, but you're also like pushing yourself, right? You're not.
Yeah.
You know,
hard play. Okay.
There was that study, I think it was JAMA Medicine, the one that was published in December 2017, where they did the dose response and intensity of exercise. They took Parkinson's patients and had a group of them, you know, basically not do any exercise. Another group did moderate intense, so they were doing about 60 to 65% maximum heart rate. And the other one was high intense, where they're about 80 to 85%. Again, people that aren't measuring their heart rate, you know, when you're sweating and you're flush, I mean, that's kind of a good indicator when you feel uncomfortable because you're pushing it. You know?
Right, exactly. That's a good example.
This was a 6-month trial, and the people that did not exercise, according to the various the tests that they measure for disease progression, and we talked a little bit about this. There may be, you know, there's some caveats there, but according to that, you know, test they do, the people that did not exercise progressed 15% worse over the 6-month trial. The ones that did moderate intensity progressed 7.5%, so about half of what the ones that didn't exercise. And the people that did high intensity had 0 progression over 6 months, which to me is huge when I think about Parkinson's disease. And a friend of mine's, a really close friend of mine who happens to be a neurologist as well, she specializes in motor dysfunction as well. Her mother has Parkinson's disease, and I've watched her progress over the last 15 years. And I've seen it progress from tremor, a little bit of the gait problems, to now she can't walk, she can't dress herself. I mean, it's progressed now, full-blown dementia. So there's definitely a progression there. And I'm wondering, it's like, if you could take someone and have them, in the study they did, it was 3 times a week, and it was about 30 minutes of the intense exercise with a little bit of a warm-up and cool-down. And if you could take someone and have them do an intense workout like that 3 times a week, and slow the progression where you're talking, you know, just having a little bit of a tremor and maybe some of the slowness, you know, maybe just a little bit of that in initial stage, but like having their quality of life where they can still dress themselves and put their makeup on and, you know, like they still have their mind. I mean, that's a huge difference in quality of life.
Right, that is huge. That is huge. And I think, and again, I mean, we still have a lot of room to go. I mean, we understanding how this affects Parkinson's disease, we've got some really great promising data. I think there's still gaps, particularly, I would say, still in the cognitive realm. We've got a lot to do there in terms of understanding what that cognitive impact really is. And again, we talked about the idea that cognition impairment is common in Parkinson's disease, probably is finally the biggest disability over time. So obviously work to do there, but certainly we're heading in the right direction in terms of, one, trying to understand through many different types of studies, both clinical and in animal models, to try to understand how well they can impact these different circuits, particularly cognitive circuitry as an example. And then also, I think the cool thing is, you're right, we actually have some data, without a doubt, that we can use now, right? And so the idea of definitely making sure that our patients are well informed in terms of the idea that it's important, right? So they need to be using, you know, we always say 50% of treatment should absolutely be lifestyle, and particularly exercise and all the things we just talked about, and making it intense, having a physical therapist that can help you really challenge yourself. We talked about gait and balance because that tends to be the bigger issue. And when you train gait and balance, it's going to incorporate many other different things, making it intense, partly aerobic, partly from practice. Those are all important. One of the things I have to say, though, that I always try to make clear to people is, one, there's no data that it stops disease. So that's the one thing. It's never shown that it cures Parkinson's. And two, I also want to make sure that we inform patients that it's not a replacement for dopamine. And the reason that's important is because we also had some experience with individuals who were frightened of dopamine, and I know there's a lot of literature out there that can be very frightening for people, but the idea that they weren't taking dopamine all they wanted to do was exercise. And what we noticed is that those people really struggled. I mean, they really were not able to get the most out of practice. They got a lot of fatigability when they tried to exercise, and so the point was they didn't really get the benefits of exercise because they couldn't do it, right? And so the other part of the equation is there's a reason for dopamine, right? And so dopamine has a role for synaptic plasticity. Obviously, practice is important, but dopamine enables.
Can you talk a little bit about, so there's the standard of care treatment right now is levodopa, carbidopa, right? And
Right, so dopamine replacement, because Parkinson's disease, as I said, causes obviously dopamine depletion with circuit changes, but the dopamine depletion is also what's driving some of this loss of connections. We need dopamine back because dopamine is what enables synapses to form as well, along with practice, and it also alleviates the symptoms themselves. So treating with L-DOPA will help a lot of the symptoms of slowness and stiffness that will allow you to get the most out of practice. I can move better. I can move more accurate when I can, I'm not feeling slow or stiff. So, again, I think of the L-DOPA, which is what we give, carbidopa, levodopa.
L-DOPA gets converted into dopamine.
L-DOPA, so L-DOPA is a prodrug that I ingest with carbidopa. Carbidopa blocks the peripheral metabolism of L-DOPA, so it doesn't break down in the blood or make me sick.
So carbidopa prevents L-DOPA from becoming dopamine before it gets into the brain.
Right.
Is that right?
That's correct. Okay. And then, but the idea there is once L-DOPA makes it into the brain, it gets converted in the brain in those remaining cells to dopamine. And that is now targeting those circuits that I mentioned, the automatic circuits, right? And that's what allowing it to work more efficiently. And then the idea is with adding exercise, it may also drive repair.
Right. So you're saying that exercise is not a replacement for the L-DOPA, carbidopa, but it's in combination, because you obviously still need the dopamine, and I think that the L-DOPA and the carbidopa itself doesn't actually slow disease progression, but it does help treat symptoms. But that's after a certain time, doesn't some of those become refractory? It's
more. I would say there's several points. One is that because those cells are not storing it as well, you're having to dose more frequently, so that's a cell dysfunction problem. Mm-hmm. And then secondarily, there are other circuits, cognitive circuits as an example, that are getting affected, and we know cognition plays a big role in my ability to move safely through space, and so that's going to be a big contributor. And L-DOPA does not do as much. It's not as effective for cognitive function. It has a role there, but it's one of many different chemicals, acetylcholine being another one, serotonin, norepinephrine being other ones.
These things are also modulated by exercise, and there have been meta-analyses that have been done looking at various types of exercise and their effect on cognitive function, executive function, global cognitive function, memory. And those things can be improved by
particularly the aging.
Intense.
Right, an aging field, I'd say, is a little further ahead of us in terms of their data. It's probably the strongest data is in the aging field right now.
Absolutely, right. It is. But there are some with Parkinson's patients that they have looked at, and so it certainly is affecting cognition as well at the exercise. So again, it's just like doing that. I just feel like it's like driving it home. Like it seems. How do you, we hear about exercise and how important it is, like, every day in the press. I mean, everyone's heard it, the question is, like, how do you get your patients that have Parkinson's that may be sedentary, maybe, not, there's quite a few people that are sedentary in their late 60s.
Yeah.
And how do you convey the importance, how critically important it is to do exercise along with their treatment?
Yeah. I think one of the first things I would say is education. I mean, I think having the data, that's huge. So, it's one thing to say, okay, exercise is important. The other thing I would say, now we have a lot of data, and I think getting the word out, but more importantly, showing the data, what we're seeing, why we think it's happening, definitely adds some motivation. I find many times when I talk to my patients about it, they're pretty motivated after I talk to them. I think the other thing too, like anything else, having some goal setting, being clear in your mind why you're doing this, right? So the educational piece, what I'm trying to get out of it, having resources, clearly. I think most people like to have things that are close and available to themselves. So identifying resources that are close to them, classes that are close to them, and then, having other kind of motivators in your life, people around you that support you. So I'm definitely a big believer in community, and that health and wellness start at the level of community. And so having those sorts of support system to help you want to change your life, want to get more active is important. I have to tell you, many times when I'm talking to people with Parkinson's about exercise, I turn and look at the whole family and go, this is not Parkinson's specific, just saying, right? This is about everybody here. So I think, that's helpful, because I'm like, no, it's not just Parkinson's. I think all of you could start working on this. So getting the partner out there, whatever, is important as well. I'm not saying it's always easy. I mean, heck, we're talking about changing your whole Western culture here because we're sedentary, right? So small steps are good steps, and trying to get the word out, keep them motivated, find different ways, mix it up. These sorts of things are huge. I think we still have a lot of work to do. Obviously, I think there's a lot of other issues in Parkinson's that make them a little bit more vulnerable. I mean, apathy and these sorts of things. So it's not always easy. I'm not saying that it is. So clearly something we need to work on in Parkinson's disease, but I would also say kind of our culture in general.
It sounds like it'd be easier also to intervene earlier, like if you're, some of that stuff gets worse.
It is, but I have to tell you, I for me, it's like everybody. Yeah, I don't let anybody off the hook.
Yeah.
Nobody.
Good. I mean,
I'm vicious.
I think also just communicating to the patient that's like, look, there's one thing that it's affecting your symptoms. Okay, yes, there's an improvement in your symptoms, and they think, well, I can get that from my pill, right? But talking about like the way this disease will progress, like 5-10 years from now, like potentially
that should be motivating enough.
And go this pill isn't going to do that. Like it's going to help with your symptoms and stuff, but that's a big deal.
Yeah, and I think those sort of testimonials. I mean, again, it gets back to the communities and stuff. Having other people talking about what they're doing is so helpful. So it's certainly not just from us. It's from, again, their own support groups and stuff like that. I think is extremely helpful to get people motivated and making it a community-based event as opposed to PD-specific or AD, which is not that at all, right? So the whole aging goes back into the aging field and trying to think about how to incorporate this into our lifestyle as part of our culture. I think those are things we certainly need to work on more, but yeah.
Yeah, totally. A couple of things I just wanted to mention quickly before we wrap up. I know you may not be so familiar with this field, but more like the nutritional aspect. There's been some interesting evidence with the omega-3 fatty acid DHA, which is an important component of cell membranes in the brain. That's been done. Observational studies have shown like people taking fish oil have a lower incidence of Parkinson's, but you can never establish causation. Some interesting animal models, both rodents and primates, showing in the MPTP model where you kind of induce this Parkinson's-like symptoms, that the taking pretty high dose of DHA specifically, what would be a human equivalent a dose of like for a 180-pound man, like 3 grams a day, pretty much, which is like 6 pills of the standard fish oil. Like, it in both the rodent models and the primate models, non-human primate models, lowered the L-DOPA-induced dyskinesias that can happen. And I thought that was pretty interesting because it is a negative side effect that can occur with that levodopa, carbidopa, and the fact that it was like multiple animal species, the same thing was happening. And, I thought that was a very interesting finding that I kind of just wanted to get on your radar. Yeah. Just get on your radar. Maybe you can look and read in the field a little bit more about that. So, and of course, DHA, interestingly, has been shown to affect dopamine in the context of traumatic brain injury in animal models as well. So there's probably something going on there.
Right, exactly. Yeah, I think, the whole diet field, I think, and again, lifestyle, diet and exercise really go together, right? So absolutely, I think the diet field is tremendous, and it's going to give us a whole nother way to think about, again, how these things are interacting. And I have to say, for right now, I would say in the Parkinson's field, not as much. We're, again, probably, more in the aging field, but I think in general, we borrow from each other's field, but I think probably the most comfortable thing that we feel safe in saying would be something like the Mediterranean diet, again, again, based on epidemiological data, and that, of course, includes things like fish and less sugar and higher and, just green vegetables and vegetables in general, nuts and legumes and stuff like that.
Do Parkinson's, people with Parkinson's disease have a higher, for example, higher levels of plasma circulating inflammatory cytokines in their plasma?
Yeah, so there's some data. Interestingly, that, there are hints here and there. It's, again, not as well worked out as, MS, for example. But yeah, the idea that there's, TNF alpha, IL-6, so the idea that there may be higher pro-inflammatory cytokines, and that's something that we're going to try to explore in some of the work that we're doing right now. So we, people do believe that, again, it may not be the cause of Parkinson's, but maybe something that's adding to the progression, which is things like inflammation, what role diet, the microbiome, they all start tying together there, that may play as a mechanism is going to be important, and something that definitely needs to be investigated further. So again, another place where we may be able to modulate the disorder.
Yeah, but right now it seems as though the thing that's pretty repeatable is the exercise. And,
Yeah.
And that's, do you tell them 3 times a week?
Yeah, I mean, we basically, most of the studies are about 3 times a week. So I would say about 3 times a week, minimally 30 minutes, 3 times a week, and trying to make it as, intense as possible. Yeah, and then we add that as part of that should also have some skill component, particularly involving gait and balance related task, and there's a lot of things that do that. So I don't pick out any one in particular. I don't, whether that's Tai Chi, yoga, surfing, whatever they like to do. Yeah. I think that's important as well. And I think, as you pointed out before, having someone to give you the feedback so that you're accurate and challenging yourself is actually quite important. So I think having that one-on-one, particularly in Parkinson's, is a smart thing, and we do try to get people into some one-on-one therapy. I usually do at least 2 times a year, and actually I start right away. And there isn't anybody that I don't send, because we can always make it challenging for you.
I think absolutely that's really key. I think that having someone there that's going to really help push you past your comfort zone, give you that feedback.
Yeah.
I just it's really important for people, particularly people that are less prone to push themselves. Like right. I'm one of those people that I'm pushing myself. I want to be the hardest working girl in my spin class. Like I'm like, that's right. But I'm also, I don't have these neurological problems and apathy and all this other stuff that comes along with Parkinson's disease. And
right.
I've been younger, and this is sort of my personality.
Right.
So getting someone to do that, push themselves, it's so key. Oftentimes, I might say to someone, exercise is really important. They're like, well, I walk my dog. And
yes, I hear that a lot around here. I know.
I walk my dog. Well, that's good.
Right.
But you're red in the face and sweating. Are you pushing yourself? Are you running with your dog? Are you running with your dog?
Right.
So,
exactly. You got to be tough. You got to be a little tough. And anyway, I try to be pretty tough. But also, like I said, there isn't anybody. I don't care if they're even been in a wheelchair. I'll try to get them up. We'll see what we can do. I'm not, we do everything safely, but I think that was that I'm so passionate about that, because, when I was in field, it's been a while, obviously, but, I was in the field at a time where exercise was not thought like that. In fact, it was pretty much thought it couldn't do anything. And so patients with Parkinson's disease, we may give them a wheelchair or walker, but there was no plan to make it hard. And I think that's the thing in general. I think people kind of feel like, as you're getting older, just chill and don't do anything. And it's like, no.
People are afraid of falling.
They're afraid. No, I think it's this idea that somehow you can't gain something from, or you just can't do it. I'm not sure. But so forget that. Yeah, no, everyone is.
Do you see improvements with your people that have more severe? They're more.
Everybody gets better. I mean, we see improvement in everybody. I think that's the thing. And even small gains are good gains. I mean, so yeah, and I like them to mix it up. I tell them to play instruments even to get more hand skill going. And I think that's the thing. We are, in a way, we're too easy on each other. And as people get older, it's like, get out there and learn something. Go out there and learn a new skill. Take up racquetball. I mean,
are there is this a common for clinicians in the Parkinson's field? Are they commonly emphasizing exercise? Do you know? Is this something that's been more embraced, or do we have to push it more?
In general, it's been more embraced, but I have to say, in general, I'm very.
Well, you do research
I'm
on
harsh.
it. I'm
harsh.
You've got the data.
I don't let anybody get away with not talking to patients about lifestyle, and I think the data is pretty clear. And this is not just Parkinson's. 50% of any neurological disorder is lifestyle. And I'm very honest. I tell everybody, I tell all my residents, whenever I'm educating people or whatever, going around with rounds, 50% of any discussion of treatment has to be lifestyle. And if you're not doing that, you're not giving a fair balance of what we really know. And I think that message, loud and clear, and there's no excuse anymore.
And it's never too late. It's never too late.
Never too late.
Well,
right.
Thank you so much, Giselle, for this discussion and for all the wonderful research you do.
Thank you so much.
Very thankful. Thank you.
Thank you very much. Thanks.
You made it this far. Don't stop now. Click like and subscribe. Thank you for watching, and see you next time.